তাহলে যদি কমপ্লিট প্যারালিসিস হয় তাকে বলবো হেমিপ্লেজিয়া, if it is incomplete paralysis that is called the hemiparesis. So it is a loss of power one half of the body, left or right. It is a loss of power. How to examine power? Do you know? When the patient complains when patient complains that there is loss of power, you have to examine the power. What is the power of the limb? তো আওয়াজ কম হয়েছে, settled. What is the power of the limb? So you know how to examine the power of the limb. There are some gradations in the power of the limb, 0 to 5, right? You know all these things. So 0 means there is almost no movement, and 1 is there is flickering of movement, and power 2 is patient cannot move the limb against resistance, against gravity, but can move along the gravity. Can you know? Do you know how can you test this power grade power 2? Power 0 is no power plus flickering. Then gravity neutral. When the gravity is neutralized, patient can move the limb. When the gravity is neutralized, how it can be examined? Yes, patient is asked to drag his leg along the bed, not to lift the limb. So it is along the gravity is neutralized, and then it is against gravity. Patient is asked to flex the limb. If he can flex the limb, then he can move it against gravity. And next it is 4. It is against resistance. Then you put a resistance on the limb and ask the patient to flex the limb. If you can feel that if you can overcome this resistance, you are just pulling the limb in the opposite side. He is asked to flex the limb, and if he can flex the limb and at least try, and you can feel the resistance, he is trying and he is trying to flex the limb, then is it against resistance. And power 5 is full power, no power loss. So first you have to check the power of the limb. If the patient is telling there is a loss of power, so you have found that it is a loss of power is there. So it is a hemiparesis. Now some examiner comes and tells what case ki, what is your case? It's a neurology case. Yes, you start. What is your case? So you have to start your proceedings in a proper way, in a good manner, in a disciplined manner. How it can be done? My next slide is this. You just go on telling all these things. Neurology examination starts with all things are there. The patient is written 52 years male patient, okay. Then conscious, cooperative, orientation. So you know all these things, how to test these things. You know, I suppose you know this. The patient is conscious, cooperative, orientation to time and space. What are the questions to be asked? And then retains recent and past memory. Don't try to tell it like that. Sir, memory is normal. Is normal. Not like that. You just try to tell the things in a story form. Not that it is scattered. In this way, it hears better. You are telling this just as a story. Now, yes, now right hand is a right-handed person. You have to telling all these things, because next in hemiplegia, you know, the question will come: which hemisphere is dominant? So you start like this telling. Right, you are not missing anything in the higher function. See, the right-handed person, speech is normal. There is no signs of meningeal irritations. Now, in your next neurological examinations, there is no such space to examine meninges, head and spine. There is no category is there. Like a motor, you have your sensory reflex like this, but you will miss all these things if you don't tell it now. There is no signs of meningeal irritations, and head and spine is normal. Then the head and spine is normal. Then after that, his head and spine is normal. On examination, now you start your examination with the cranial nerves. Now see, after that, if you read all of this, all the cranial nerves have been tested. And you have told it in a best 4-5 lines. All 12 nerve has been tested, and you have told it in a 5-7 lines. How can we tell it? You know that on examination the cranial nerves are, there is no complaint of smell and visual acuity. First and second nerve. Eye movements are normal. Third, fourth, sixth normal. No squint or diplopia. Here also fourth and sixth, diplopia. No difficulty in mastications. Here 5 comes. No loss of sensation in the face. 5, again 5. No facial asymmetry. 6th, 7th nerve. Facial asymmetry is a 7th nerve, because if there is 7th nerve palsy, we will get a deviation of the limb, deviation of the angle of the mouth to the opposite side. So there is a facial asymmetry. I have told about 7th nerve. Then comes the taste preserved. Taste, is a glossopharyngeal is the posterior to third, anterior to third is by chorda tympani. Chorda tympani. Chorda tympani nerve is the branch of the facial nerve in the middle ear. But the fibers, all the taste fibers come from the nucleus, what is called nucleus of Tractus Solitarius, NTS, nucleus of Tractus Solitarius. Here, anterior fibers comes through 5th nerve, from 5th nerve goes to 7th nerve, through chorda tympani goes to anterior to third of the tongue. We have to know the pathway, how it goes. But taste sensation nucleus is same, nucleus red. From nucleus tractus solitarius, again the nerve, some fibers goes to the glossopharyngeal nerve and supplies the posterior to, 1/3 of the tongue. So anterior, if you want to trace from fifth one branch from pterygoid nerve to pterygoid, from there to facial nerve to chorda tympani, then anterior. This way comes. So anatomically it belongs to 5th nerve, but anatomically it belongs to 7th nerve, but functionally it belongs to 5th nerve, the anterior to third of the tongue. So if you told them what is the taste sensation of the anterior to third of the tongue, you should tell like this way. So it is anatomically belong to 7th nerve because it is supplied by chorda tympani, but functionally it belongs to 5th nerve, because 5th nerve from the nucleus tractus solitarius nerve came through 5th nerve. It came out of the brain through 5th nerve. Then it goes to 7th nerve. So functionally it belongs to 7th nerve. Anatomically it belongs to 7th nerve. And posterior 1/3, no issue. It is all along glossopharyngeal nerve. So taste sensation. No history of vertigo, deafness and tinnitus. Here we are telling about 8th nerve. No, 8th nerve. Tinnitus, vertigo, 8th nerve I have told. Then it is no history of nasal regurgitation or food of hoarseness of voice. These are no the regurgitation as a glossopharyngeal nerve. I want to tell. There is no what you examine on glossopharyngeal nerve. It is a nasal regurgitation, whether there is any nasal regurgitation or not. So food and hoarseness of voice and dysphagia. Neck and shoulder muscles are normal. Neck and shoulder muscles is supplied by what? By cranial accessory. Accessory has 2 parts, the cranial accessory and spinal accessory. So this accessory is a nerve supplied by accessory nerve, neck and shoulder muscles, and no wasting of tongue. Now it is 12th nerve. So I've started from 1 and ended in 12th. Hypoglossal nerve. What is the features of hypoglossal nerve? There is a tongue wasting. So in this way, what to tell? Most of the cases you will be interrupted by the examiner. If you want to tell like this, the examiner will not listen up to the 12th nerve. In the midway, he will interpret. But you start telling like this. If the examiner is he is not interested or thinking some other things, then go on telling up to the 12th nerve. Unless until he is interrupted. You are interrupted by the examiner. Most of the cases will be interrupted by the examiner. Yeah. Next, our cranial nerves, through the is our discussion about hemiplegia. So, I will go to hemiplegia first. Hemiplegia means So, hemiplegia or hemiparesis. Hemiparesis is a partial loss of power. Hemiplegia is a complete loss of power. Now hemiplegia lesion, here testing the power. Where is the lesion in hemiplegia usually? Where is the lesion usually? Hemiplegia? Here? No. Spinal cord, there will be no facial hemiplegia. I told you it is a complete hemiplegia means there is a loss of power. There are facial, half of the face is also gone. So there are hemiplegia. One is called complete hemiplegia. Complete hemiplegia means there is the half of the body and the half of the face of that side. Half of the face of that side. That includes complete hemiplegia. Another is called crossed hemiplegia. So complete hemiplegia. So this is complete hemiplegia. One half of the body and face of that side. Here the lesion is in the internal capsule of the opposite side. Internal capsule, you know, if this is internal capsule. Why internal capsule? Because the fibers are, unless the fibers are very much compact, it is not possible to have so much big surface of paralysis. Because you know, if it is a suppose this is a paralysis, is a cortex. Cortex has got motor cells called beige cells. Then fibers comes. This cortex, motor cortex, fiber comes. This is called choroidal radiata. Fibers come like this because there is a full motor cortex. Suppose this is the right side. And here hemiplegia is in the left side. So I am taking the example of right side. Right side cortex, motor fibers come from the cortical cells or called base cells. Base cells are grey color. Neurons are white color. Neurons are grey color and the fibers are white colored. So it is the grey color, grey material there, cortex, so called beige cells. From there the fiber comes, it is called corona radiata. If there is a lesion here, it is not possible to have hemiplegia. Some fibers will go, suppose some leg fibers or some upper limb fibers will go. But it is not possible to go all the fibers at a time because the lesion used to have to be so much big lesions. Unusual, whole of the brain should go. Possible if there is a whole brain goes, like a total MCA tertiary infarct. Possible. A total MCA is a middle cranial artery. The total MCA tertiary infarct, the whole brain goes. Yes, everything will go. Hemiplegia possible, but usually that does not occur in most of the cases. Most of the cases the lesion is very small because the thrombus is small. That will go to the most of the cases. It will go to the smaller arteries. It will go from the larger arteries, go to the smaller arteries. Then will stop somewhere in the distally. So it is a coronal radiata is not possible. If there is a lesion there, yes, possible. There is a one limb lesion called monoparesis. Now you know that the fibers are like this. That here is the head. These are leg fibers. Okay, leg fibers are here, and the person is lying like this, and here is the head. This is where the distribution is there. The head fibers low and the leg fibers up. So if the lesion is here, it is possible to go only for leg fibers. Not the head and upper limb fibers will be spared. If it goes here, the upper limb is like to be affected, but not the lower limb will be spared. So, in coronary radiata, there is a possible only monoparesis, not clumped hemiplegia. Now, these fibers are consolidated in a structure called internal capsule. Here they are ekdam complete. They are actually this is a posterior limb. This is anterior limb. This is a posterior limb. This is the internal capsule. Internal capsule. This is the posterior limb and the anterior limb. This is called genu. This is called genu. Okay, genu. And this is anterior limb and this is a posterior limb. So all fibers are compacted in the genu and the posterior limb of the internal capsule. Here also, if their fibers are distributed like this, in the genu fibers there. Now, so only these lesion here, very small lesion can cause all the fibers paresis. It's very small lesion. Most common lesion is a lenticulostriate branch of the MCA. It's the most common lesion. A direct branch, a lenticulostriate branch of the middle cranial artery, middle cerebral artery, MCA, lenticulostriate branch. It is from the middle cerebral artery. It arises from the middle cerebral artery, very small arteries called lenticulostriate branches. That supplies the internal capsule. So, most of the cases hemiplegia is due to lesion in the internal capsule, possible artery, possible, I cannot tell it definitely, but possible artery involved is lenticulostriate branch of the middle cerebral artery. Now here after that it forms a corticospinal tract. Now the fibers are coming down, corticospinal tract. After the corticospinal, then it comes to the midbrain. It will come to the midbrain. Then you know that midbrain they will get some nucleus. That day I discussed whether you with the group or not. I don't know. But cranial nerves are distributed in 2 to 4 manner. Forebrain 2, midbrain 2, 1, 4, and medulla 4. First and second, forget it. But third and fourth is very important. They are in the midbrain. So here midbrain he will get third and fourth midbrain supply. But the corticospinal tract usually supplies the cranial nerve of the both side in almost all cases, except 2. Corticospinal tract, it is coming from the left side. It is coming from the right side. On the right side. Now it is after coming like this, and after that in the medulla, it will cross to the opposite side. You know that it cross to the opposite side. The right sided lesion will cause left sided hemiparesis. Left sided hemiparesis, but cranial nerves are not involved. If it is an internal capsule. Why cranial nerves are not involved? Because cranial nerve supplies on both sides. Because these are right. If you go in the, if it is in the right side, it is right third and fourth. It is also supplied by the left nose. Left half of the brain. So all cranial nerves are supplied bilaterally. So lesion in the corticospinal tract in the internal capsule do not cause cranial nerve lesions. But I have told that except 2 cranial nerves, they are not supplied bilaterally. This is the upper half of the upper half of the face. If you seventh nerve nucleus, if you tell seventh nerve nucleus is like this, then it is the upper half and the lower half. Upper half has bilateral supply. And lower half is only supplied by the opposite. Lower half is only supplied by the opposite side. That's why if it's like this, it will affect the seventh nerve. Upper half has both supply and the lower but the lower half has only supply from one side. That's why if the facial nerve here the facial nerve in the this is the right side, facial on the right side, means the right side facial nerve, then right lower face will go, right upper face is supplied by both sides. Got my point or not? Not clear? Right facial here, right side, dealing with the right side of the facial nerve. Right side of the facial nerve nucleus has got two parts, upper part and lower part. Upper part is supplied by both sides, and the lower part is supplied by the only right side. That's why when the lesion goes, upper half is spared because it is supplied by the opposite side also. But lower half is affected because it is only supplied from that side only. Got this now? That's why the upper face is spared. Follow?
Right side lesion will cause
বল হ্যাঁ লেফট সাইডে গন্ডগোল করে না, তোমার রাইট সাইডে লিশন হলো, তো রাইট সাইডে ফেশিয়াল নার্ভ গেছে, রাইট সাইডে ফেশিয়াল নার্ভ তোমাকে রাইট সাইডে ফেসকে সাপ্লাই করছে,
right side is
lower halfটা যেহেতু সাপ্লাইড বাই ফ্রম দ্য লেফট সাইড অলসো, দ্যাটস ওয়াই দ্যাট ইজ sorry, upper half is supplied by both sides, so upper half is spared because upper half is spared, the lower half that from that side, that's why it is affected. Got my point now? Upper half is spared because of its supply. Just simply tell this as why the upper half is spared, because upper half is spared because it's supplied, the upper half of the neuron is supplied by the both side. That's why the only lower half of the impact. সেই সাইডে হচ্ছে, সেই সাইডে তোমার এই গেছে তো এই সাইডের ফেশিয়াল নার্ভ, হ্যাঁ হ্যাঁ তোর এটা না এটা তো তোর হ্যাঁ বাইলেটারাল সাপ্লাই, একটু গন্ডগোল হতে পারে, দাঁড়া বাইলেটারাল সাপ্লাই তো এনিওয়ে তো বেগেট গেছে রাইট সাইডে ফেশিয়াল নার্ভ গেছে, রাইট সাইডে ফেশিয়াল নার্ভ এদিকে তোর না, এটা তোর বাইলেটারাল সাপ্লাই কর্টিকোস বাইলেটারাল সাপ্লাই দিয়েছো দুদিকে ফেশিয়াল নার্ভ এক মানে try to get the answer that it is a sir upper half of the facial nerve that side, ওই সাইডে তো ফেশিয়াল নার্ভ প্রপারে ক্রস করেনি, ওই সাইডেই আছে, যে সাইডে হেমিপ্যারিস ওই সাইডে ফেশিয়াল নার্ভ গেছে, তো সে তো সেম সাইডই হচ্ছে, আর সেই সাইডে ফেশিয়াল নার্ভ আপার হাফটা স্পেয়ার করে গেছে বিকজ অফ দ্যাট ইট ইজ সাপ্লাইড বাই বোথ সাইড। কিন্তু যদি ফেশিয়াল নার্ভটা এইখানে যায়, ধর এই যদি আমার ফেশিয়াল নার্ভটা দেখা যায় যে তোর পুরোটাই গেছে, পুরোটা যেতে পারে কি কারণে, যদি লিশন অন দ্যাট সাইড হয়, ঠিক আছে, লিশন অন দ্যাট সাইড যদি হয়, তাহলে যদি ফেশিয়াল নার্ভ অ্যাট দ্য সাইড, এখানে যেমন এটা আমি বললাম যেটা লিশন ইজ ইন দ্য রাইট হাফ অফ দ্য সাইড, কিন্তু ইন দিস কেস ইফ ইট ইজ দ্য লিশন ইজ on the left facial nerve লেভেলে গেছে, facial nerve is in the level of the তোর 2-2-4 যদি হয় তাহলে it is in the pons যদি পনেসে কোনো লিশন হয় তাহলে কিন্তু তোমার আপার হাফ লোয়ার হাফ দুটোই গেছে, আপার হাফ লোয়ার হাফ যদি চলে যায় তাহলে এখানে যেটা হবে সেটা হচ্ছে ক্রসড হেমিপ্যারেসিস হবে, ক্রসড হেমিপ্যারেসিস, এটাকে বলে ক্রসড হেমিপ্যারেসিস। ক্রসড হেমিপ্যারেসিস মানে হচ্ছে যে লিশন ইজ ইন দ্য অ্যাট দ্য লেভেল অফ দ্য সেভেন্থ নার্ভ, যেখানে প্যারাসিসটা এরকম হবে কিন্তু ফেশিয়াল প্যারাসিসটা হবে উল্টো দিকে, তখন এইটা হবে না, এটা হচ্ছে ক্রসড হেমিপ্যারেসিস হবে, তখন হবে এইদিকে, এটা হচ্ছে ক্রসড হেমিপ্যারেসিস, যেদিকে প্যারাসিস হয়েছে তার উল্টো দিকে ফেশিয়াল প্যারাসিস হচ্ছে। আগেরটা বলেছিলাম কমপ্লিট হেমিপ্যারেসিস, এটা হচ্ছে ক্রসড হেমিপ্যারেসিস। ক্রসড হেমিপ্যারেসিস মানে হচ্ছে যে লিশনটা হয়েছে রাইট সাইডেই কিন্তু অ্যাট দ্য লেভেল অফ দ্য ফেশিয়াল নার্ভ, যার জন্য অপোজিট সাইডের কর্টিকোস্পাইনাল ট্র্যাক্ট গেছে, অপোজিট সাইডের কর্টিকোস্পাইনাল গেছে, ফেশিয়াল নার্ভের লিশন হয়েছে, তখন তো কর্টিকোস্পাইনাল ট্র্যাক্ট ক্রস করেনি, ইট হ্যাজ নট ক্রস, ইট উইল ক্রস ইন দ্য মিডলার। আমি রাইট সাইডে যদি এটা পন্সের লিশন হয়, পন্সে যদি লিশন হয় তাহলে আমার লেফট সাইডে হেমিপ্যারেসিসই হবে, কিন্তু ফেশিয়াল প্যারাসিসটা অপোজিট সাইডে হবে, বুঝা গেল? সে যদি সে হবে তাহলে দিস ইজ কল্ড ক্রস হেমিপ্লেজিয়া। What is crossed hemiplegia? It is the hemiplegia due to lesion in the level of the pons, affecting the seventh nerve of the opposite side, and hemiplegia on the other side. এগুলো করতে হবে। আচ্ছা, এবার হলো বাইরে কর্টিকোস্পাইনাল ট্র্যাক্ট, আদার ক্রেনিয়াল নার্ভস বলেছি দে আর অল বাইলেটারাল সাপ্লাই, অন্য ক্রেনিয়ালগুলো কোনো লিশন হবে না। সেভেন্থের ক্ষেত্রে শুধু হাফ লিশন হবে, বিকজ অফ দ্যাট দ্য হাফ ইজ সাপ্লাইড বাই বোথ সাইড অ্যান্ড দ্য লোয়ার হাফ ইজ নট সাপ্লাইড বাই বোথ সাইড, লোয়ার হাফ only supplied by the side only, from the opposite side only, এটা বলেছে। হ্যাঁ হ্যাঁ, না প্রন্সে যদি হয় তাহলে সেভেন, এখানে যে ফেশিয়াল নার্ভ আছে, ধর এখানে যে ফেশিয়াল নার্ভ আছে, ঠিক আছে, এ তো এখানে যদি এখানে লেফট আছে, তো লেফট এখানে এ তো লেফট থেকে সাপ্লাই করছে, রাইট থেকে সাপ্লাই পেয়েছিল, হ্যাঁ, কিন্তু যখন গেছে তখন তো টোটালটাই গেছে, রাইট লেফট দুদিকে গেছে, কারণ তো ফেশিয়াল নার্ভ এখানে লিশন অ্যাট দ্য লেভেল হয়েছে, সেখানে আপার হাফ লোয়ার হাফের ব্যাপার থাকছে না, যেখানে ফাইবার দুদিকেই গেছে, সেখানে ফাইবারটাই গেছে, আপার হাফ লোয়ার হাফ দুটোই গেছে।
আর্টেরিয়াল ব্লাড গ্যাস অ্যানালিসিস,
হ্যাঁ,
আর্টেরিয়াল
কিন্তু
ব্লাড গ্যাস অ্যানালিসিস,
এখানে আপার হাফটা স্পেয়ার করে গেছে, তার কারণ হচ্ছে এখানে আপার হাফ স্পেয়ার করে গেছে, কারণ আপার হাফ সাপ্লাইড বাই দ্য অপোজিট সাইড অলসো, বুঝতে পেরেছিস? তো এটা বলা হচ্ছে এটা কমপ্লিট হেমিপ্যারেসিস এন্ড ক্রসড হেমিপ্যারেসিস। কমপ্লিট হেমিপ্যারেসিস ইজ দ্য lesion in the internal capsule, hemiplegia on the one side, and facial nerve paralysis on the same side, and crossed hemiparesis is the facial nerve paralysis on the opposite side. The lesion is at the level of the facial nerve on the side of the face, যেদিকে প্যারালাইসিস হয়েছে, হেমিপ্লেজিয়া হয়েছে অপোজিট সাইড, ঠিক আছে। আর কারণটা কি বলে, আপার হাফ দ্য নিউক্লিয়াস ইজ সাপ্লাইড বাই বোথ সাইড, power is reduced in both, the tone is increased in upper motor neuron lesion, but tone is decreased in lower motor. Rigidity is the same. Rigidity is increased in upper motor neuron lesion, and is in lower motor lesion. That's why it is called spastic. Rigidity increased, so it is called spastic paralysis. For lower motor neuron, rigidity is decreased, that is called flaccid. It is called flaccid. Muscle are relaxed, flaccid. Again, if you examine the tone, you can feel the muscle is flexed. So it is spastic paralysis. So it is the hemiparalysis. What is the type of paralysis it is? It is a spastic paralysis, not flaccid. Flaccid paralysis will occur when there is anterior horn cell involved. Can you name some conditions where anterior horn cell is involved? Poliomyelitis, motor neuron disease. There are several anterior horn cell, but if there is a lesion in the spinal cord, syringobulbia, the spinal cord is increasing and it affects the anterior horn cell, then the anterior horn cell, when there is affection of the anterior horn cell, it is a lower motor neuron lesion, it causes flaccid paralysis. Anterior horn cell, not only anterior horn cell and beyond, up to the level of the myoneural junction. So myoneural junction involvement is myasthenia gravis. Is it a spastic or flaccid paralysis? It is a flaccid paralysis. So from anterior horn cell, poliomyelitis, motor neuron disease, up to the level of the myasthenia gravis, it's a muscle myoneural junction, and myopathy also. Muscle disease called myopathies. All this is called flaccid paralysis. In between there are neuropathies. Guillain-Barré disease, Guillain-Barré syndrome. Have listened, it's a Guillain-Barré syndrome. That causes reticulopathy, polyreticulopathy. Antibody is produced against the roots of the nerve, polyreticulopathy. So there is paralysis of the limb. Both limb may be paralysis, but in that case, paralysis should be flaccid, not spastic. But if it is a spinal cord lesion, that was spinal cord lesion, at the level of the spinal cord lesion it will be flaccid, but below the level of the spinal cord lesion it will be spastic. Got my point or not? Suppose the spinal cord lesion is at the level of the T2, then at the level of the T1, T2, T3 it may be a lower motor neuron lesion, because anterior horn cell may be affected on that side, but below T3 it is upper motor neuron lesion. because this supplies by the corticospinal tract is intact. This supplying the corticospinal tract is gone, and they will act as a the anterior halt cell will act as a loss of upper motor, loss of father, not themselves. Got my point or not? So, in case of lesion in the T2, suppose there is a patient will fall from the floor and has the fracture in the T2 level. Then at the T1, T2, T3, it may be lower motor neuron, may be flaccid paralysis, muscle supplied by T1, T2, T3. But below T3, T4, T5 and onwards, it will be act as a upper motor neural lesion of that because their father gone, but they are intact. So, there will be act as a upper motor lesion, but below that, that will be spastic paralysis. So, these things happens also in case of transverse myelitis. The same transverse myelitis, spinal cord lesions, and any spinal cord lesions. So, one two segments there is flaccid, below that there is spastic. So, if it is a paraplegia case, if the examiner it is a spastic or flaccid, it is a spastic paralysis. This is spinal cord lesions. If the paraplegia is due to Guillain-Barré syndrome, then it is flaccid paralysis, because the lesion is in the nerve, not in the spinal cord. Spastic paralysis of both the lower limb is only possible upper motor, up to the spinal anterior horn cell. Beyond that, no questions of so rigidity is increased. Then jerks. Several jerks, there are jerks, knee jerks. There are spinal segments of the knee jerks. Always remember the level of the knee jerks. Suppose the knee jerk is the level is L2, L3. What does it mean? What does it mean? Any lesion above the L2, L3, the L2, L3 will act as a further gone. That's why jerks increased. But at the level of the L2, L3, suffering, child is himself suffering, so there will be flaccid paralysis. So, now if I can tell you, the jerks are increasing in corticospinal tract lesions, because in case of Guillain-Barré, jerks will increase or decreased? Decreased. Classically, it is decreased for all purposes. Yes. So, jerks will be decreased in Guillain-Barré syndrome because it is a flaccid paralysis. Jerks will be increased in corticospinal tract lesions. Though in case of Guillain-Barré, some exceptions are there. Jerks may be intact, or in some cases, jerks may be intact in some cases, but that is you will not have to remember. You remember, you being a MBBS student, remember the classic things. In case of Guillain-Barré, jerks will be decreased. But you remember all these things. In few cases, what happens, you don't remember. So, jerks will be decreased because it is a lower motor neural lesion. Then plantar. Plantar will be extensor. It will flexor in lower motor neural lesion. So, power is gone, tone decreased, rigidity is spastic paralysis, this is flaccid, and jerks will be decreased. What? Yes? Any question? Plantar reflex the extensor hobe? Extensor means corticospinal tract lesion, upper motor neuron lesion. All corticospinal tract lesion means upper motor neuron lesion. And jerks will be decreased in or unaffected in lower motor neuron lesion, not affected. So, it is a case of paraparesis. Suppose the lesion is at the level of the T2. Plantar will be plantar supply, it is S1, S2. S2, S3. So, it is a sacral supply. So, in case of thoracic lesion, suppose paraparesis, trauma or transverse myelitis at the level of the T2, then plantar will be what? Extensor or flexor. In case of paraparesis, I told you the spinal cord lesion is spastic paraparesis. Beyond spinal cord, it is flaccid. So, as the trauma or transverse myelitis is a spinal cord lesion, it is spastic paraparesis. Plantar will be extensor, because the lesion is above the S2. Lesion at the level of S2, plantar may be equivocal, maybe flexor, whatever. But below the any lesion below the above the level of S2, plantar will be extensor. This is because it is spastic paralysis. Huh? Right. Well, yes. S2 নিচে S2 নিচের লিশন কোথায় হবে তোমার কড়া ইকুনে তাহলে কড়া ইকুনেতে গেছে সেখানে আনএফেক্টেড কিন্তু S2 তোমার S2 গেছে মানে তোমার তো ওখান থেকে লাম্বার বেরিয়ে কটা ইকুইনা আর স্যাক্রাল আর 3-4টে বাকি আছে কটা ইকুইনা সিনড্রোমে হচ্ছে সেখানে ইউজুয়ালি অ্যাঙ্কেল সেখানে তোমার S2 গেলে অ্যাঙ্কেল রিফ্লেক্সটা লস্ট হয়ে যাবে অ্যাঙ্কেল রিফ্লেক্সের সাপ্লাই ধরো তুমি এবার জাক্সের ব্যাপারে আমরা আসছিলাম যে নি জাক L2 L3 তেমনি অ্যাঙ্কেল জার্ক রয়েছে S2 S3 সেগুলো মনে রাখতে হবে লেভেলগুলো মনে রাখতে হবে এবার বাইসেপসে তো 3-4 এইগুলো মনে রাখতে হবে যে কোন জার্কসের কী লেভেল এটা বলতে পারো না তোমরা পরীক্ষা মনে রাখতে হবে যে আমার নি জার্কটার স্পাইনাল লেভেল কত মানে নি জার্ক মানে কি আমি এটা হঠাৎ কোয়াড্রিসেপসটাকে স্ট্রেচ করছি রিফ্লেক্সটা স্পাইনাল কর্ডের কোন লেভেলে আছে L2 L3তেই আছে সেখান থেকে ব্যাক করে এসে কোয়াড্রিসেপসটাকে কন্ট্যাক্ট করাচ্ছে তো ইট ইজ এ L2 L3 একটা লোকাল রিফ্লেক্স ওখানে একটা লোকাল রিফ্লেক্স স্ট্রেচিং অফ দ্য কোয়াড্রিসেপস goes to the L2 L3 to the posterior limb থেকে তারপরে স্ট্রেচিং করেছি posterior limb দিকে স্ট্রেচিংটা তো একটা সেন্সরি রিফ্লেক্স সেন্সরি অল রিফ্লেক্স goes to the posterior limb posterior দিকে গিয়ে তারপরে anterior horn cell এসে একটা লোকাল রিফ্লেক্স আর তৈরি করেছে জার্কস হয়েছে বাট দ্যাট জার্কস ইজ এফেক্টেড বাই দ্য corticospinal tract that is influenced by the cover. Usually it maintains it in a moderate way. But if the corticospinal tract goes unabated and there will be increased jerks. But if the corticospinal tract is intact, then there will be normal jerks. If the corticospinal goes, then there will be increased jerk. But at the level of the lesion, no jerk. In this way, the level of the lesion at the level of the L2 L3, the jerk will be lost. Because the level is at L2 L3. Then S2 S3 level lesion that he was asking S2 S3 level lesion of the quad equina syndrome the ankle jerks is lost because the level is at the level of the S2 S3 like that. So this is the difference between the upper motor neuron lesion and the lower motor neuron lesion. These are the things asked in hemiplegia cases. Now I have told about the site of the lesion. What is the arteries in these are the common questions asked what is the site of the lesion what is the arteries asked what is the arteries involved it is a complete hemiplegia or crossed hemiplegia if it is a complete hemiplegia face is the upper face is spared like this and crossed hemiplegia and lower at the site of the lesion as I told about your facial nerve but in all the cranial nerves, other cranial nerves are spared because it is supplied by both sides. But if the lesion is at the site, suppose at the lesion is at the midbrain, then third, fourth nerve may be involved. Because midbrain, if there is an involvement in the midbrain, then there will be involvement of the third nerve on the same side and hemiplegia on the opposite side. Because that corticospinal tract will cross to the opposite side. Third nerve lesions. Midbrain third nerve lesions, there will be here now. Muscle wasting. Muscle wasting can occur both, but muscle wasting is the features of lower motor neuron lesions. Because the anterior horn cell, blood supply to the muscle goes to from the anterior horn cell. That's why blood supply is impaired. If the anterior horn cell is gone, blood supply of the muscle is impaired and there is atrophy of the muscles. So atrophy of the muscle is the features of lower motor neuron lesion. But it occurs in the upper motor neuron lesions due to disuse atrophy. That is called disuse atrophy. Disuse means that if you do not use your limb for a prolonged time, there may be some atrophy. That's called disuse atrophy. Okay, but wasting is the features of lower motor neuron lesion, for anterior horn cell lesion, not upper motor neuron. Another is fasciculation. 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 Fasciculation is the features of lower motor neuron lesion by anterior horn cell affection. Fasciculation means there is a fine tremor in the muscle. You will feel there is a fine tremor in the muscle That is called fasciculations. So wasting and fasciculations, these are two features. The features of lower motor neuron lesion or the affection of the anterior heart cell. They do not occur in the upper motor neuron. Fasciculation do not occur in the upper motor neuron lesions. Wasting can occur due to prolonged non-use of the muscle. But it is not the feature of upper motor neuron lesion. এগুলো আর একটু লোয়ার মোটরের ব্যাপারে মনে রাখতে হবে, এই দুটি জিনিস মনে রাখলেই হবে। আচ্ছা, আমরা যেটা আলোচনা করছিলাম যে আমরা একটুখানি স্লাইডে যাই। এখানে নিউক্লিয়াস আমরা বলেছিলাম যে ব্রেনের দিস দ্য ডিস্ট্রিবিউশন অফ দ্য নিউক্লিয়াস ইজ আ ফাইন পিকচার অফ দ্যাট। আমরা বলেছিলাম এই যে মোটর এখানে প্রথমে এই যে থার্ড অকুলোমোটর নিউক্লিয়াস, ফার্স্টে আমরা যদি যাই রাইট সাইডে অকুলোমোটর নিউক্লিয়াস, দ্যাট ইজ থার্ড নার্ভ নিউক্লিয়াস, that is the midbrain. Oculomotor, trochlear nerve nucleus, this is the midbrain. So midbrain has two nucleus. That's the trochlear is the upper oculomotor nucleus and trochlear nucleus. So oculomotor is if the lesion is at the level of the midbrain, third nerve of that side may be involved. So in that case, the involvement will be third nerve of that side and the lesion in the opposite side. Okay, third nerve lesion on the same on the third nerve. You know the features of third nerve lesion. There are আগের দিন পড়েছিলাম, তোমাদেরই কাদের পড়ালাম, অনেক করে পড়ালাম যে ফিচার্স অফ থার্ড নার্ভ lesions. One is ptosis, drooping of the upper eyelid, and is dilatation of the pupil. আর আরেকটা ফিচার, and eye will be looking downwards and out, down and out. এক্সপ্লেনেশনটা আমরা বলেছিলাম যে কারণ the lateral rectus is intact, lateral rectus and superior oblique is intact. That's the eye look. এই ফিচার্সটা একটা সাইডে হলো, আর একটা সাইডে হেমিপ্যারেসিস হয়েছে। তার মানে the lesion is at the level of the midbrain, at the level of the third nerve. অপোজিট সাইডে থার্ড নার্ভ কাছে, তাহলে থার্ড নার্ভ, থার্ড নার্ভ নিউক্লিয়াস আমরা এখানে গেলে তাই হবে। আচ্ছা, এবার হচ্ছে এছাড়াও কিছু আমরা আলোচনা করেছিলাম সেদিনকে যে থার্ড নার্ভ কীভাবে যায়। মিডব্রেনের ভেতরে থার্ড নার্ভ তিনটে জিনিস ক্রস করে। আমরা বলেছিলাম যে it crosses three structures. It goes through the red nucleus, it passes by the side of the medial limb discus, and it goes by the side of the corticospinal tract. তো আমরা এখানে যেটা বললাম সেটা corticospinal tract-এর কথা বললাম, যে একটা ওয়েবার সিনড্রোম বলে এটাকে, হ্যাঁ, ওয়েবার সিনড্রোম, যে কর্টিকোস্পাইনাল গেছে থার্ড নার্ভ গেছে। এছাড়াও ওইখানে রেড নিউক্লিয়াস যেতে পারে আর মিডিয়াল ল্যাম্ব ডিসকাস যেতে পারে। রেড নিউক্লিয়াস গেলে আমরা সিনড্রোমের নাম করেছিলাম, সেটাকে বলে কি বলে, রেড নিউক্লিয়াস একদিকে গেল আরেকদিকে ক্লট সিনড্রোম। এরকম আছে, রেড নিউক্লিয়াস হচ্ছে এটা পিরামিডাল সিস্টেমের, সেটাকে আমরা অ্যাটেক্সিয়া হতে পারে। তা এই যে আমরা মোটর এতক্ষণ ধরে পড়লাম মোটর সিস্টেম, that motor system is not only corticospinal tract, other two systems also affect the motor powers like coordination and everything. So there are other two systems that are extrapyramidal system and cerebellar system. These also affect the motor functions. Coordination, you know that extrapyramidal system, what are the extrapyramidal system? The basal ganglia, substantia, basal ganglia, red nucleus, these are the part of the extrapyramidal system. These also affect the coordination of the movement. Coordinated movement is possible only if there is intact pyramidal, extrapyramidal and cerebellum. All three should be intact for a normal motor function. Any one affected, you know, the basal ganglia affection is occurs in Parkinson's disease. In Parkinson's disease, the features are there is ataxia, fascinant gait. So these are not normal motor functions. These are not, motor functions is also affected by the extrapyramidal system. That extrapyramidal system also can cause rigidity. This here the rigidity is called clasp knife rigidity. Clasp knife rigidity. In extrapyramidal system, it is called lead pipe rigidity. Rigidity has different type. Clasp knife, this is called spastic rigidity, means the throughout the clasp knife. The lead pipe rigidity and a cogwheel rigidity. With the clasp knife. Here it is called clasp knife rigidity. In the corticospinal tract, it is called clasp knife. Clasp knife means when you want to close a knife, in the initial part of the closing and the last part of the closing, that feels your resistance. In the middle part, no resistance is less. It is called clasp knife. You are just closing a knife. This collapse knife rigidity is a classical example of but late pipe rigidity. When the rigidity is failed throughout the movement, this is called late pipe rigidity. That is occurs in extrapyramidal system. Another rigidity also called cogwheel rigidity. This is also a part of the extrapyramidal system, cogwheel rigidity. So rigidity can occur not only in pyramidal tract lesion, but also it can also occurs in extrapyramidal lesion, like Parkinson's disease. But the rigidity is different. So, and cerebellar in a cerebellum lesion is important because it causes coordination. If you want to finger nose, we do the finger nose test in cerebellum, because if you want to touch your nose, it is a very coordinated movement. You are not pass pointing the nose. Even if you close your eyes, you know the where your nose is. You touch it. Otherwise, the intact cerebellum, it is not possible. You have intact corticospinal tract, you can contract, okay. You have intact extrapyramidal, no rigidity, okay. Everything. But if the cerebellum is not intact, then even if you have normal power and normal everything, you cannot touch your finger with your nose, with your finger at the nose. It will pass point. Even if you open your eyes, it will pass point. Because it's pass pointing, is the the coordination of movement is not there. This is also a cerebellar function. It's pass pointing. So, read by this also, not only corticospinal tract, this extrapyramidal tract, like extrapyramidal lesion like Parkinson's disease occurs due to dopamine deficiency in substantia nigra, and also other extrapyramidal system, and also in cerebellar disease, like cerebellar ataxias. Fine movements and proper voluntary movement not possible. Okay. Anyway, so we are going to the cranial nerves. Then this is the trigeminal nerve. Then abducens nerve. This comes in the your pons. Pons has got these lesions. They have abducens nerve, vestibular nerve, facial nerve. These are the nucleus system. Now you can see that last four nucleuses are in the in the medulla. Spinal accessory last there, spinal trigeminal. You can see the trigeminal nerve has peculiar nucleus. One nucleus of the trigeminal nerve has started from the midbrain. See the length, this one, okay. One trigeminal nucleus, one of this nucleus of the trigeminal nerve is very peculiar. It has started in the midbrain and ended in the spinal cord. Almost it is entered the spinal cord. This is the nucleus of the trigeminal nerve carrying the spine, the temperature, pain, and temperature sensation. Now, trigeminal nucleus is very important, very interesting. Go and read. It has the nucleus one in the pons is there. There is a trigeminal motor nucleus that supplies the muscles of mastications. Muscles of mastication. Motor trigeminal nerve supplies the what? Muscles of mastication. Pterygoid, masseter. These are the muscles of mastications. Chibanoর জন্য যেসব muscle দরকার. They are supplied by trigeminal nerve. That nucleus is in the pons. But another sensory nucleus of trigeminal is there. Trigeminal has got another sensory nucleus which carries general sensation from the face. General sensation from the base. But pain, temperature, sensation, the nucleus is started from the midbrain, from the midbrain and ended in spinal cord. Okay, no? These are all important because all things cannot be. Go and read the features of Wallenberg syndrome. This is your task, home task. Next, if I meet you, I will ask all of you I will ask, so what are the features of Wallenberg syndrome? What are the type of anesthesia? Unless you have the concept of this facial nerve, unless you have the concept of this trigeminal nerve, the pain temperatures, sensation of the trigeminal nerve, peculiar nucleus, you cannot explain the sensory defect of a Wallenberg syndrome. Wallenberg syndrome also called lateral medullary syndrome. Lateral medullary syndrome. This is your home task. Go and read and try to understand the sensory loss and try to why this sensory loss. Why it is in the medulla, lesion is in the medulla, but sensation in the loss in the face, helmet like called helmet-like anesthesia loss. Why? But it should not affect. There is a lesion is in the medulla, but it affects the sensory loss in the face. Why? You cannot explain it unless you know the position of this nucleus like this. It is your home task, okay? Everybody, today, not tomorrow. Today you go to home and read the features of Wallenberg syndrome. Everything features of Wallenberg syndrome. They were an explanation why this type of sensory loss, and also features of syringobalbia. Another task. Syringobalbia. One lesion is pressing from outside Wallenberg, vascular lesion. Another issue is syringobalbia, pressing from inside. So pressing from outside and from inside is different, because the spinal cord, suppose in a spinal cord, the spinal canal is expanding, which will affect first crossing of the spinothalamic tract is just in front of the spinal canal. Got my point now? Spinothalamic tract, they carries the pain and temperature sensation from the body. They cross the body at the level. At the level they cross, but not at the level, actually 2-3 segments they cross. So from my leg, fibers of the spinothalamic goes, they cross 2-3 segments and goes down. Just that's crossed in front of the spinal canal. So if the spinal canal increases in size, first affection is in the spinothalamic tract. Then nearer to the spinothalamic tract is anterior horn cell. Then it will affect the anterior horn cell. Motor functions. First pen temperature, then motor functions. In this way, the thing. And the last will be the posterior column, because posterior column is very far away from anterior the spinal canal. So anatomy you will have to know. So this picture is important. Just আমার একটা পিকচার তো কষ্ট করে এনেছি তোমাদের জন্য দেখিয়ে দিই, তাহলে বুঝতে পারবে। এটা আমরা আগের দিন বলেছিলাম যে yesterday with the distribution of third nerve, that is it is going through the red nucleus, oculomotor nuclei. Oculomotor nuclear distribution. It is important because this midbrain lesion is a very favorite questions of the examiners. So I told that medial limb discus affection is called Benedict syndrome, red nucleus affection is called Clot syndrome, and this corticospinal is called Weber syndrome. Third nerve, red nucleus, এটা পড়। তারপরেরটা পড়বে। আচ্ছা, এইটা আমি জাস্ট এটা এনেছি এই কারণে যে এফেকশনগুলো, এটা ক্যাভার্নাস সাইনাসের ছবি, ইজ এ পিকচার অফ দ্য ক্যাভার্নাস সাইনাস। একটা ক্যাভার্নাস সাইনাস can be affected by this sphenoidal sinus infections or some hypercoagulable state, everything. But here the particular lesion is like all the cranial nerves we have discussed has come to this cavernous sinus. All the eye muscles, eye nerve, they go third, fourth, sixth, in ophthalmic division of the maxillary, and fifth nerve of ophthalmic trigeminal first two division of the trigeminal nerve, and carotid artery. All are the content of this cavernous sinus. Cavernous sinus is very important because it is commonly affected by sphenoidal sinus infections, which is close to. And another is very close to pituitary fossa also. Another is very close to pituitary fossa also. So any affections there can affect the, and the carotid artery aneurysm. Carotid artery just passing inside it. So carotid, if there is carotid artery aneurysm, then these nerves may be affected. Third, fourth, sixth. Now, that may simulate. You can see that probably it is a case of brainstem lesion. No, very much mimicking a brainstem lesion, like a cavernous sinus lesion, because all the cranial nerves are in that sinus only. That's why it can mimic a brainstem lesion. This is the perimetry I have discussed in that way. Perimetry of the